Okay, so my topic was candidiasis. My patient was one of the patients I had while I was at the TDCJ prison. She was a 25-year-old female who complained of vaginal discharge for the past week. She had a past medical history of uncontrolled insulin-dependent diabetes. She's currently refusing her insulin treatment. She also has a history of hypertension, diabetic neuropathy, and she had an IUD placed in 2013. So she complained of a thick white vaginal discharge with itching and no odor. She denies any sexual activity since incarceration a year ago. Her last menstrual period was 2 years ago before her IUD was placed. When we asked her about her personal hygiene, she stated that she washes her underwear in the sink with hand soap along with all the other inmates. They do this because they think if they send the underwear to the laundromat, they'll get exposed to diseases. We also asked her about her eating habits and her diet. And she said she buys cookies and ramen off commissary frequently and is non-compliant with the diabetic diet. She doesn't have any drug allergies. She's currently on aspirin, hydrochlorothiazide, lisinopril, and nortriptyline. Only abnormality on exam was mild erythema noted in the labial folds in the external genitalia. Vaginal mucosa was coated with a thick white homogeneous discharge. No lesions noted on internal or external genitalia. Her cervix was normal, and we also did not note an IUD string on the exam. Her labs, hemoglobin A1C of 10.3, glucose of 298, blood pressure 135/89, pulse of 98, respiratory of 18, BMI of 34, and a temperature of 97.1. My differentials for her were vaginal candidiasis infection or yeast infection, bacterial vaginitis, gonorrhea, chlamydia, HIV, AIDS. We decided that her diagnosis was most likely a yeast infection due to her history of uncontrolled insulin-dependent diabetes with no current treatment and the appearance of the discharge on exam. Our plan for her was fluconazole 150 milligrams once per day for 7 days. We also ordered a CBC with DIF, KOH wet prep, and HIV or STD testing in case she was exposed to anything from any of the new current inmates. We also informed her of her missing IUD string and referred her to GYN for IUD removal. We also educated her on the importance of taking her insulin and the comorbidities associated with her uncontrolled diabetes. We also told her about signs to look for related to DKA and educated her on the proper diabetic diet and what foods she should avoid, what foods she should eat. We also educated her on the importance of cardio and exercise for 30 minutes each day. So a little background on candidiasis. It's the most common opportunistic fungal infection, which is usually caused by an overgrowth of Candida albicans. It can be caused by other species, but that was the most common. And because it's commonly opportunistic infection, it is seen in immunocompromised patients. The infection can be a variety of places in the human body. The mucocutaneous candidiasis was one of the most common forms of the infection. 3/4 of women will experience a vaginal infection at least once in their life, and candidiasis or candida is now the 4th most common isolated pathogen in blood cultures. Since candidiasis can infect multiple sites, just kind of like a background of how it would present in most cases. Generally, the affected area will begin with an erythematous rash with some pruritus or pain. The rash can be described as individual vesicles that spread into large coalescing conflicent areas. This type of fungal infection prefers warm, dark, moist areas. An example of this would be the armpit skin folds or the genocrucial folds. In its most severe form, the fungal infection can have a thick white discharge that will cover the affected area, and a way to tell this from others is that it can be scraped off. So in a vaginal infection, it'll have vaginal or vulvar erythema, swelling, burning, or pruritus, burning when the urine touches the skin, dysuria, dyspareunia, or a thick curd-like white discharge. Complications, most cases resolve with the antifungal treatment, but if a case is untreated or resistant to treatment, it can become systemic, which is candidemia, and this infection can occur and lead to death in 30 to 40% of patients. So differentials for vaginal candidiasis could be bacterial vaginosis, trichomonas, chlamydia, or gonorrhea. So ways to diagnose it. First, you would want to consider a fungal infection in any patient that is unresponsive to broad-spectrum antibiotics. You can always do a culture of the area, wet mounts, KOH prep, blood cultures if you think it's systemic, urinalysis if you think it's a renal infection, or a sputum gram stain if it's a pulmonary infection. Imaging is not typically useful in the diagnosis. Specific to a vaginal diagnosis, the urine pH will be normal, the whiff test will be normal, but the microscopic test will have a KOH prep showing budding hyphae. The general medical treatment would be an antifungal administered in the route appropriate for the infected site. So for a vaginal infection, the treatment of choice is PO fluconazole, 1 dose for 150 milligrams. So in conclusion, candidiasis is a fungal infection commonly found in immunocompromised patients. In its mildest form, it can present as an erythematous painful rash with white discharge. At its most extreme, it can enter the bloodstream, possibly leading to sepsis or death. Candidiasis can be found almost everywhere in the human body. As long as it is treated promptly with antifungals, it will be usually resolved. If left untreated, it can result in death in most severe cases. So now for my questions. My first one is, a 40-year-old female with a history of diabetes presents to your clinic with complaints of vaginal discharge. KOH prep was done and shows budding hyphae. What is the best way to treat this infection? Ceftriaxone, doxycycline, metronidazole, fluconazole, or tindazole? The correct answer is D, fluconazole. My second question, a 50-year-old male with a history of HIV presents to your clinic with complaints of a sore throat. On exam, you note his oral mucosa contains a thick white patches as well as angular cheilitis around the mouth. You grab a tongue depressor blade and find that you are able to scrape off the white material. Based on your knowledge of HIV, what is the CD4 count? At what CD4 count would this patient first become susceptible to getting this opportunistic infection? A CD4 count of 25, B, CD4 count of 355, C, a CD4 count of 800, D, CD4 count of 110, or E, CD4 count of 600. Correct answer is B, a CD4 count of 355. And that's the end of my presentation. If you have any questions, post them on the board. Thanks.